So good afternoon to all. So we are going to learn about the bipolar affective disorder or mood disorders. Under this session, we will cover mania, depression, bipolar. So few points regarding the history of affective disorder. The first record of bipolar disorder in medical text goes back to Hippocrates in 400 to 300 BC, a doctor from ancient Greek known as father of the medicine. Hippocrates referred to deep sadness as melancholia. The word melas means black and chole means bile. So it is translated to black bile. And he believed that mania was caused by excess of yellow bile. So these are two poles in bipolar disorder. One is known as depression and another one is mania. Another Greek doctor, Aretius of Cappadocia, is recognized for introducing the idea of mood spectrum. He also identified the melancholia and mania were linked to issues in the brain, not in the bile. Both Hippocrates and Aretius distinguished between these types and argued that melancholia and mania were biological conditions rather than just psychological conditions. In 1854, Julius Farlet describes the cycles of depression and mania in his literature Jolie Circulaire. In 1882, German psychiatrist Karl Kalbaum defined the term cyclothymia and linking mania and depression as the part of same illness. He considered depression not as a separate illness and the mania as not the separate illness but as a spectrum of a one disorder. In 1899, Emil Kraepelin expanded on the ideas of earlier French and German psychiatrists, defining manic depressive psychosis with criteria that are still used today and as diagnosed as bipolar 1 disorder. Kraepelin also noted that manic depressive psychosis was different from dementia precox. Dementia is an illness of older age, and uh, the dementia precox word was meant for dementia which has an early onset of illness, which means precox. So he differentiated manic depressive psychosis from dementia precox because it did not lead to a mental decline. In case of schizophrenia, there is a progressive decline. In the dementia also there is a progressive decline, but this is not in the case of manic depressive psychosis. There are episodes of mania and depression, and in between the episodes there is a period of normalcy. He also described a type of depression called involutional melancholia. So a mood disorder is a mental health issue that mainly impacts the mood. It is a condition where you go through a long times of very high happiness and very deep sadness, or sometimes both. Some mood disorders also include other strong feelings like anger and irritability. Mood disorders, previously called as affective disorders, are now preferred because they describe long-lasting emotional state. What is affect? Affect is an immediate expression of emotion which one can observe at the cross-sectional point of time. But in case of disorder, this is a pervasive change in the mood. So it is called as mood disorder rather than affective disorder. By definition, mood can be defined as a pervasive and sustained emotion or feeling tone that influences a person's behavior and colors his or her perception of being in the world. So terminology used in context of bipolar disorder or mood disorder are depression, mania, hypomania, bipolar, unipolar disorder or recurrent depressive disorder, dysthymia and cyclothymia. You can see in the graph there is a period of there is a period of euthymia, means all the emotions are within the normal range, and further there is a fluctuation of mood to the above side and downside, but not crossing the limit of mania and depression. And this can be considered as mixed episode where both manic features and depressive features are uh, happening together. This is the another graphical representation of unipolarity and bipolarity. In unipolar depression, uh, there are only episodes of depression or dysthymia, and this can be a single episode, a recurrent episodes, or dysthymia. Dysthymia means uh, subtle symptoms of depression are present, but not up to the threshold of depressive disorder. In bipolar disorder, one can have bipolar 1 disorder, bipolar 2 disorder, cyclothymia, or unipolar hyperthymia. In bipolar disorder, one can have either manic episodes or depressive episodes also. But in unipolar disorder, there are only depressive or dysthymic episodes. Now coming to the epidemiology, incidence and prevalence. Lifetime prevalence rate of depressive disorder ranges from 5 to 17% and average is 12%. Lifetime prevalence means in the whole life, 5 to 17% of patients can have depressive episodes. Lifetime prevalence of bipolar 1 disorder is 0 to 2.4%, bipolar 2 disorder is 0.3 to 4.8%, and for hypomania, this is 2.6 to 7.8%. Among the gender, women are about twice as likely as men to experience major depressive disorder. Bipolar disorder affects men and women equally. However, men tend to experience more manic episodes, while women are more likely to have depressive episodes. When women do have manic episodes, they often shows a mix of mania and depression. In females, the abundance of mixed episodes are there. Additionally, women are more frequently rapid cyclers. Rapid cyclers means if a person is having more than 4 episodes of either of mania or depression in the whole previous year. As per the age, bipolar 1 disorder usually starts earlier than the major depressive disorder. It can begin in childhood, sometimes as young as 5 or 6 years old. Manic episodes in older people are rare instances and with an average of starting age of 30 years. In contrast, depressive disorder typically begins around 40 years of age, with half of the case starting between 20 and 50 years of age. It can also start in childhood or later in the life, but most common is the middle age. Regarding the marital status, major depressive disorder is more common in people who lack close relationships and in those who are divorced or separated. So social support is important as a causative factor of major depressive disorder. Bipolar 1 disorder is seen more frequently in divorced and single individuals compared to the married ones. But this may be due to the early onset of the disorder and the marital problems that follow after developing the bipolar disorder. In socioeconomic and cultural factors, there is no link between socioeconomic status and major depressive disorder. However, bipolar 1 disorder is seen more often in higher socioeconomic groups. People with bipolar 1 disorder are less likely to have graduated from college, which may relate to the younger age of onset at which the disorder typically starts. Depression occurs more frequently in rural areas than in the cities. The rate of mood disorder is similar across the different races. Still, there is a tendency for doctors to miss mood disorder and mistakenly diagnose schizophrenia in patients of different racial or cultural backgrounds. In etiological factors, there are mainly two types of factor. One is biological factor, another is psychological factor, and third one is social factor. In biological factors, there are biogenic amines, and out of the biogenic amines, norepinephrine and serotonin are the two neurotransmitters most implicated in pathophysiology of mood disorder. The downregulation or decreased sensitivity of beta adrenergic receptors in the brain and clinical antidepressant response in reversal is in the favor of this biogenic amine theory. Low levels of serotonin can lead to depression. Some patients who have suicidal thoughts showed reduced amount of serotonin metabolites in the cerebrospinal fluid and fewer serotonin uptake sites on the platelets. Dopamine thought to be involved as well. Research indicates that the dopamine levels might be lower in depression and higher in mania. What are the biogenic amines? Biogenic amines are norepinephrine, serotonin, and dopamine. Other neurotransmitters which are involved are choline, which help produce acetylcholine, have been found in the brains of some patients with depression during autopsy. Agonists of acetylcholine can cause tiredness, lack of energy, slowed movement in healthy people, worsen symptoms in depression, and lessen symptoms in mania. So this has have been seen with the choline levels. Lower levels of GABA receptors have been seen in plasma, CSF, and brain tissue in those with the depression. Glutamate may work with the high cortisol levels to contribute to the harmful cognitive effects of severe recurrent depression. New evidence indicates that drugs blocking NMDA receptors may have antidepressant effects. Lots of neurotransmitters are involved. Other biological factor may be second messengers and intracellular cascade system. When some neurotransmitter attach on the receptor of that neurotransmitter, this is followed by a cycles of chemical reactions, which is as follows. A cascade of membrane bound and intracellular process mediated by second messenger system. Enzyme inside the cell like adenylate cyclase, phospholipase C and phosphodiesterase cause creation of second messengers like cyclic AMP and cyclic GMP. There is also growing evidence that mood destabilizing medication affect G protein and other second messengers. Now, what about the hormonal regulations? The activity of gene responsible for producing brain-derived neurotrophic factors, which is known as BDNF, decreases after prolonged stress. High activity of HPA axis is a key feature of stress. The presence of high cortisol level in depression indicates possible central issues because of the cortisol. About 5 to 10% of individuals assessed for depression may have previously unnoticed thyroid issues. Thyroid issues can be there. Lower levels of somatostatin in CSF has been noted in depression, while higher levels are seen in manic episodes. Additionally, a reduced prolactin response to a certain serotonin agonist have been observed, which is rare in premenopausal women, indicating that estrogen may play a role in the response of the drug. Now coming to the psychosocial factor, life events and environmental factors or environmental stress can be a causative factor for depression. For example, infections, especially intrauterine infections, and most implicated infection is rubella infections during the pregnancy. Maternal smoking during the pregnancy. There is 2.5-fold higher risk of bipolar disorder in offsprings delivered by planned cesarean. Climate also have role. For example, seasonal affective disorder are there seen in some patients that the episodes usually occur in a particular season, and seasonal effects supposedly influence the regulation of mood. A history of childhood trauma is common in mood disorders. Life events like bereavement, interpersonal problems, financial crisis, work-related problems, failure, and job loss also have implication in development of mood disorder. Social support may trigger or alter the course of illness and the severity. In psychosocial factor, there are personality factors also. Personality disorders like obsessive compulsive personality disorder, histrionic or borderline personality may be at the greater risk for depression. Patients with dysthymic disorder and cyclothymic disorder are at risk for later developing major depression or bipolar 1 disorder. Psychodynamic factors. The dynamics of life, how the dynamics can affect the development of affective disorders uh, is expanded by Carl Abraham and founded by the Sigmund Freud. This theory involves four key points. One is disturbance in infant-mother relationship during the oral phase, uh, means the first 10 to 18 months of life, predisposed to subsequent vulnerability to depression. Depression can be linked to real or imagined object loss. Introjection of the departed object is a defense mechanism invoked to deal with the distress connected with the object loss. So this theory you must have learnt in the psychology lectures if you have gone through the uh, psychology part. And the lecture may be taken in further sessions regarding the psychodynamic factors. The fourth one is because of lost object is regarded with a mixture of love and hate. Feeling of anger are directed inward at the self. The anger directed towards the self means the person has developed self-harming tendency or suicidal tendencies. Melanie Klein viewed depression as a way of showing anger towards those we care about. Edward Bibring saw depression as arising when someone realizes that they cannot achieve their very high ideals. Edith Jacobson compared depression to a child who feels weak and helpless, suffering at the hands of harsh parent. Silvano Ariti noted that many people with depression have focused their lives on others instead of themselves. John Bowlby thought that early emotional wound and traumatic separation in childhood make a person more likely to experience depression. Now, what happens in mania psychodynamically? This is considered as a defense against underlying depression. Abraham believed that the manic episode may reflect an inability to tolerate a developmental tragedy such as loss of a parent. A manic state can happen when a harsh superego causes extreme self-criticism, which is then swapped for a feeling of great self-satisfaction. Bertram Levin saw the manic patient's ego as a being overpowered by strong desires like sex or by feared urges like aggression. Melanie Klein also thought of mania as a way to defend against depression, using manic defenses like feeling all powerful, where the person believes they are much greater than they really are. Other formulations of depression are cognitive theory given by the Aaron Beck, which has 3 points. One is views about self as a negative self-percept, about the environment, a tendency to experience the world as a hostile and demanding, about the future, the expectation of suffering and failure. Now come to the diagnosis. So we have discussed that there are two poles. One is mania, one is depression. We will start with the clinical features and aspects of depression. Depression can have single episode, which is categorized as mild depressive episode, moderate depressive episode, severe depression with or without psychotic symptoms as per International Classification of Diseases, 10th version. Regarding the stability of diagnosis of depressive disorder, 25 to 50% of patients were later reclassified as having a different psychiatric condition or a non-psychiatric medical condition with psychiatric symptoms. So in the follow up or in the future, the diagnosis may change. For example, if a person is having a first episode at this point of time, the diagnosis will be depressive episode or depressive disorder. And in future, she may have manic episode, then the diagnosis will be changed to bipolar disorder. If the person is having two subsequent consecutive depressive episodes, the diagnosis will be recurrent depressive disorder. Okay. By the time diagnosis may be changed. Now the clinical features of depression, there are two types of features. One is core symptoms or major symptoms. Another is minor criteria. In the major symptoms, there is depressed mood, loss of interest and enjoyment or anhedonia, reduced energy leading to increased fatigability and diminished activity, marked tiredness after only slight effort is common. So these are the three main features. Out of three, one must be present to say the person is having depressive episode. The minor criteria are reduced concentration and attention, reduced self-esteem and self-confidence, ideas of guilt and unworthiness, even in the mild type of episode, bleak and pessimistic view of future, ideas or acts of self-harm and suicide, disturbed sleep, and diminished appetite. So out of these symptoms, there are three grades of severity, and the duration of at least 2 weeks is required for diagnosis. But shorter period, when usually the symptoms are severe and of rapid onset, can be diagnosed as a depressive episode before the 2 weeks also. The characteristic of symptoms are the lowered mood varies little from day to day. This means this is pervasive and long lasting and is often unresponsive to circumstances. If there is a incidence of happiness in the family, the mood will be remain low and intensified. Yet may show a characteristic diurnal variation as the day goes on. Within the day, the person can have diurnal variation of mood, having intensified lowered mood in the morning time, and by the day goes on, the mood improves by the evening. Anxiety, distress, and motor agitation may be more prominent at times. Mood change may also be masked by added features such as irritability. Irritability can mask the depressed mood. Excessive consumption of alcohol can also mask the symptoms. Histrionic behavior, exacerbation of pre-existing phobic or obsessional symptoms, or by hypochondriacal preoccupation, the symptoms may be seems masked. There are the symptoms of special clinical significance, such as lack of emotional reactivity to normal pleasurable surroundings and events. Uh, Walking in the morning 2 hours or more before the usual time, the routine may be changed. Depression worse in the morning, this is diurnal variation. Objective evidence of definite psychomotor retardation or agitation. There may be marked loss of appetite, and because of this, the person can have weight loss also, often defined as 5% or more of body weight is lost in past 1 month. Marked loss of libido may be there. We had discussed about the psychotic symptoms in depression, like severe depression with psychotic symptoms. What are the psychotic symptoms? Psychotic symptoms are classified as delusions, hallucinations, marked psychomotor retardation, agitation, and catatonia. In delusion, common themes of mood congruent delusion includes delusion of guilt, delusion of persecution, punishment, personal inadequacy, or disease may be present in case of severe depression with psychotic symptoms. Hallucinations are usually transient and limited to single words or short phrases and generally saying things consistent with the patient's depressed mood. So mood congruency is there. Psychomotor retardation, it means that a person thinks more slowly or moves less This can lead to noticeable delays in physical and emotional reactivity, such as in their speech and feelings. In agitation, example includes restlessness, tapping, starting and ending tasks abruptly, fidgeting, pacing, hand wringing, fast talking, racing thoughts, crowded thoughts, moving objects for no reasons may be signs of marked psychomotor agitation. In catatonia, there are set of motor symptoms like posturing, masked faces, and excitement. So catatonia is also considered as psychotic symptoms. In severity of depression, one can have mild, moderate, or severe episode. In mild depressive episode, one can have two major core symptoms of depression and two minor symptoms. In moderate, this may be two plus three minor symptoms or four minor symptoms. In severe case of depressive episode, it shows considerable distress or agitation unless retardation is marked feature. Loss of self-esteem or feeling of uselessness or guilt are likely to be prominent, and suicidal tendency may be present. We had talked about the melancholic features, melancholic depression. The features of melancholic depression characterized by severe anhedonia, early morning awakening, weight loss, and profound feelings of guilt, often over trivial events. Suicidal ideation, suicidal tendency is not uncommon in melancholic depression. It is associated with changes in autonomic nervous system and endocrine functions. Melancholia is sometimes referred to as endogenous depression, which means depression that arises in absence of any external life stressor or precipitants. There is a term called as depression with atypical features. The atypical features can be significant increase in appetite. We had learned that there is a loss of appetite, but in atypical depression, significant increase in appetite may be seen. Oversleeping or hypersomnia may be there. Latent paralysis, where your arms and legs feels heavy, may be the feature. A long-term pattern of rejection sensitivity, when you interpret ordinary or slightly negative social cues as rejection. So these symptoms have sometimes been referred to as reverse vegetative symptoms, and the symptom pattern has sometimes called hysteroid dysphoria. Clinical presentation, the patient may present with the feelings of hopelessness, worthlessness. Patient may be unable to cry, may be having suicidal tendencies. Sometimes they do not complain of mood change. They do not acknowledge their mood is low or depressed, although they are withdrawn from family, friends, and activities that can be observed by the others. Complaints of low energy, difficulty completing tasks, deterioration at school and work, and low motivation to start new projects may be the chief complaints or presenting complaints. Trouble sleeping, especially early morning awakening. Terminal insomnia is there. Multiple awakening in between the sleep may also be there. Anxiety is a frequent sign of depression and impacts up to 90% of people with depression. The patient may not present with the core symptoms. The patient may present with the symptoms of anxiety. So you have to find out whether the patient is having depression or anxiety disorder. Other vegetative symptoms include abnormal menses and decreased interest and performance in sexual activities. In children and adolescents, the features may be different from adults. The features may be school phobia. Strong attachment to parents can indicate depression in children. In teenagers, sign of depression may include low grades in school, drug use, antisocial behavior, risky sexual activity or sexual promiscuity, skipping school, and running away from the home. In older adults, depression is more frequent in older adults compared to the general population, and prevalence rate can range from 25% to near 50%. Studies suggest that factors like low socioeconomic status, losing a spouse, having a physical illness, and social isolation may be linked to the depression, which is common in the elderly people. Depression in this age group is often not diagnosed or treated properly, especially by the general doctors, because this may happen because older adults often express depression through physical symptoms. So they are more focused on their physical sign and symptoms. Ages might lead providers to view depressive symptoms as a normal part of aging. This may be the factor why the elderly people often not diagnosed or treat properly because of the depression. Now coming to the another pole, which is mania. In mania, the features may be having a very high level of energy or activity. The features you can acknowledge that uh, these features are opposite of the features of depression, like very high level of energy and activity, extremely happy or excited mood, and almost euphoric affect may be seen. Not needing much sleep yet feeling refreshed, there is a decreased need for sleep, having an inflated sense of self-worth, grandeur ideas or delusion of grandeur may be there, talking more than usual, patient may be over talkative, experiencing racing thoughts. Thoughts are flowing with a faster rate and can be observed as flight of ideas in the speech sample. Getting easily distracted, being overly focused on a specific activity, showing restless movement like pacing and fidgeting, acting impulsively, for example, excessive spending, risky sexual behavior, or unwise investments. The psychotic symptoms in manic episode may be present like hallucination and delusion, but are in the different form. Delusion are false beliefs that seem real but are not based on the reality. The patient may have paranoid delusion, may have inflated sense of their own abilities, delusion of grandeur or grandiose delusion, the inflated self of power or importance of self. Mania in teenagers. The presentation may be different from the adults. The teenager may be present with or mistaken for the antisocial personality disorder or schizophrenia. Signs of mania in this age group can include psychosis, substance abuse, suicidal attempts, difficulties in school performance, deep philosophical thinking, OCD-like behavior, various physical complaints, significant irritability leading to conflicts and other antisocial actions. While some of these signs can be found in typical teenagers, if symptoms are severe or last a long time, healthcare providers should think about the bipolar 1 disorder as a possible diagnosis. In classification of manic episode classified as hypomania, mania without psychotic symptoms, mania with psychotic symptoms, other manic episodes, manic episode unspecified. So this is the classification for bipolar affective disorder. In this disorder, more than one episode is present and at least one episode is of hypomania or mania. So this is classified as bipolar affective disorder, current episode hypomania or current episode manic without psychotic symptoms, manic without with psychotic symptoms, further mild or moderate depression, severe depression without psychotic symptoms, severe depression with psychotic symptoms, and the patient is having current episode as mixed or currently the patient is in remission means patient is in follow up and is having none of the symptoms of depression or manic at the present time. What the mixed episode is, A diagnosis of mixed bipolar affective disorder should be made only if the two sets of symptoms are both prominent for the greater part of the current episode of illness, and if that episode has lasted for at least 2 weeks. So, as we have seen in the graph, symptoms of both depression and manic are present at the same point of time, and uh, and in the abundance equally in the numbers. Differential diagnosis of affective disorder or mood disorder, the medical disorder which may be uh, considered as having mood disorder is mononucleosis in adolescents. Markedly overweight or underweight present may have adrenal or thyroid dysfunctions. Homosexual, bisexual men, prostitutes, person with abuse of substance intravenously may present with acquired immune deficiency syndrome. In elder people, viral pneumonia should be ruled out. Cardiac drugs, antihypertensives, sedatives, hypnotics, antipsychotics, antiepileptics, antiparkinsonian drug, analgesics, antibacterial and anti-neoplastic drugs all are commonly associated with depressive symptoms, either depressive features or as a causative factor to develop a depressive episode. Neurological condition may also mimic mood disorders or associated with mood disorder as a comorbid illness like Parkinson's disease, dementing illness, including dementia of Alzheimer's type, epilepsy, cerebrovascular disease, and tumors. Temporal lobe epilepsy can mimic a depressive episode. There is a term pseudodementia, includes symptoms that look like dementia. For example, issues with speaking, remembering, and focusing. However, it usually stems from different reasons, often related to the depression. So, severe depression, which present with more of the symptoms of cognition like attention, concentration, and memory, that can be presented as dementia patient, but will fall under the diagnosis of pseudodementia. In the differential diagnosis, the differential diagnosis of a mood disorder can be an adjustment disorder with depressed mood. Alcohol use disorder often present as a depression or as a comorbidity of depression as well, along with the substance dependence. Anxiety disorder like generalized anxiety disorder, mixed anxiety depressive disorder, panic disorder, post-traumatic stress disorder may present along with the depressive features. Obsessive compulsive disorder can also have comorbid depression. Eating disorders like anorexia nervosa, bulimia nervosa can also have comorbid depressive disorder. Substance induced mood disorder can be there. Schizophrenia may also present in the phase of depression, which is known as post schizophrenic depression. Schizophreniform disorders, somatoform disorder can also present with the depressive features. So these disorder of psychiatry should also be ruled out during the assessment for comorbidity or associations. Now the course and prognosis for major depressive disorder, the first depressive episode happens before the age of 40 in around 50% of patients. If it starts later, it is often linked to no family history, antisocial personality disorder, and alcohol problems, which is more common in the younger age. An untreated depression can last for 6 to 13 months, while treated uh, depressive episodes usually last about 3 months. Stopping antidepressant before 3 months often leads to return of symptoms. As the disorder continues, patient experience more frequent and longer episodes. The subsequent episodes will be longer and more frequent. Over the 20 years, the average number of episodes is 5 or 6 in a patient. For manic episode, about 5 to 10% of patients initially diagnosed with major depressive disorder will have a manic episode 6 to 10 years after their first depressive episode. So the diagnosis will change to bipolar disorder in the future time. The average age for this change is 32 years, typically occurring after 2 to 4 depressive episodes. The one person is having 2 to 4 episodes, then there are chances that he or she will have first manic episode after the few depressive episodes. Now the prognostic indicators for major depression. The good prognostic indicators are the milder the episode, the prognosis is good. The absence of psychotic symptoms. If ever hospitalized, the hospital stay is shorter, is a good indicator. History of good social support during the adolescence or good friendship or good circle at the during the adolescent period is a good prognostic factor. Stable family functioning, generally sound social functioning for the last 5 years before the onset of illness. Absence of a comorbid psychiatric disorder is also a good prognostic factor. No more than one previous hospitalization for major depressive episode. Later age of onset. Poor prognostic factors are coexisting dysthymic disorder, abuse of alcohol or other substance, comorbid anxiety disorder, a history of more than one previous depressive episode. Uh, it is recurrent depression. Men are more likely than women to experience a chronically impaired course. For bipolar 1 disorder usually begins with depression, affecting 75% of women and 67% of men. 10 to 20% may only have manic episodes. There is no depressive episode in between. For example, the person is having 4 to 5 manic episode but has no intervening depressive episode. Manic episodes can start quickly within the hours or days but may develop after a few weeks. If not treated, a manic episode can last around 3 months. About 90% of those who have one manic episode will have another episode. So the diagnosis will change to bipolar disorder from manic episode. As the disorder continues, the time between episodes often shortens. The time gap between the two episodes shortens by the time. After about 5 episodes, the time between them usually stabilizes to 6 to 9 months. 5 to 15% experience 4 or more episodes each year and are considered as rapid cyclers. Around 40 to 50% of individuals with bipolar 1 disorder may experience a second manic episode within the 2 years of first episode. Poor prognostic factor for bipolar 1 disorder is poor job status before the illness, alcohol dependence, presence of psychotic symptoms, presence of depressive symptoms, depressive features between episodes, and being male. Good prognostic factor are shorter manic episodes, older age at onset, fewer suicidal thoughts, and fewer other psychiatric and medical issues. Approximately 7% of those with bipolar 1 disorder do not have any symptom recurrence. So this is only a 7% of person who will not have the another episode. 45% experience multiple episodes. 40% have a chronic form of disorder. Patient can have anywhere from 2 to 30 manic episodes with an average of about 9 episodes. About 40% of all patients have more than 10 episodes. So in summary, mood disorder are a type of mental health issues that mainly impacts a person's feeling in terms of sadness and happiness. They include depressive disorder and bipolar disorder. In bipolar disorder, there are bipolar 1 disorder and bipolar 2 disorder. What happens in bipolar 2 disorder is the episode of mania is not there. Instead, episode of hypomania is there. Hypomanic episode mixed with the any severity of depressive episode is known as bipolar 2 disorder. In bipolar 1, a manic episode should be there to diagnose as bipolar 1. In symptoms, mood disorder can lead to change in sleep, appetite, energy, focus, and self-worth. They arise from a mix of genetic, biological, environmental, and psychological influences. In prognosis of mood disorder, in depressive disorders, many people with depression can see great improvement with the right treatment. However, some may face repeated episodes which might need ongoing or even lifelong treatment. In bipolar disorder, the outlook for bipolar disorder is more complicated because of the cycles of mania and depression. Long-term treatment, usually including mood stabilizers and therapy, is often required. Thank you.
Now we will be covering the second part of the mood disorders. We will cover in this lecture the recurrent depressive disorder, dysthymia and cyclothymia. Recurrent depressive disorder is the condition involves not the single episode of depression, rather multiple episodes which can be mild, moderate or severe in intensity. There is no history of separate episode of mood elevation or overactivity that meets the criteria for mania or hypomania. So in this disorder, only the uh, episodes of depressive continuum will be present in the life of the person. The category should still apply if there are signs of short period of mild or mild mood increase or overactivity that meets the criteria of hypomania right after the depressive episode, which may be sometimes triggered by the depression treatment. So hypomanic episodes may be there to diagnose recurrent depressive disorder, which are immediate after the depressive episode, may be resultant of antidepressants. The age when depression starts, along with how severe, long lasting, and often it happens, can vary a lot. There is variation of involvement of age. Usually, the first episode happens later than the bipolar disorder. Each episode can last from 3 to 12 months with an average of about 6 months, but they tend to happen less often. In recurrent depressive disorder, recovery typically happens fully between the episodes, but some patients, especially older ones, may experience ongoing depression between the uh, epi- ongoing depression between the episodes of mild, moderate, or severe depression, which may be a dysthymic-like condition. We will learn about the dysthymia in the further slides. Stressful life events often trigger episodes of any severity. In many cultures, both single episodes and ongoing depression are seen twice as often in women compared to the men. So, recurrent depressive disorder is found more in the females. To diagnose the recurrent depressive disorder, the episodes of depression should fulfill the criteria of either of mild, moderate, or severe. And we had already discussed the features of depressive episode, and it is similar in the recurrent depressive disorder for the episodes of depression. So first one is the depressed mood, second one is loss of interest and enjoyment or anhedonia, reduced energy leading to the increased fatigability and diminished activity. One may find marked tiredness after only slight effort. So these three are the core criteria, major criteria to diagnose depressive episode. The minor criteria are reduced concentration and attention, reduced self-esteem and self-confidence, ideas of guilt and unworthiness, bleak and pessimistic views of the future, ideas or acts of the self-harm or suicide, disturbed sleep, and diminished appetite. In the ICD-10, the recurrent depressive disorder is classified under chapter F33, and further it is classified F33.0 as mild, 33.1 as moderate, 33.2 is severe without any psychotic symptoms, 33.3 is severe with psychotic symptoms, and 33.4 is currently in remission, means the in between period of the two episodes. Mild and moderate further has specifier It can be present without somatic syndrome and with somatic syndrome. Now coming to the persistent mood disorder, one is cyclothymia, another is dysthymia, and further classified as other persistent mood disorder unspecified. So the category F34 is for the persistent mood disorder. Now coming to the dysthymia. Dysthymia meaning ill-humored was first used in 1980. Before that, many people now seen as having dysthymia were considered to have depressive neurosis or neurotic depression. Dysthymia is different from a depressive episode which we used to find in depression single episode or in the recurrent depression. The people with dysthymia often say they have always felt depressed. Most cases starts early in the childhood or teenage years, and by the time individual are in their 20s, there is also a less common late onset type found in middle aged and older adults, and it is identified mainly through community studies, because these patient does not usually uh, try to find the uh, medical management. Dysthymia can happen as a secondary issue related to other mental health disorder like chronic other psychiatric disorder. However, it mainly describes as a mild but long lasting form of depression that lasts at least for 2 years. So 2 years criteria is required to diagnose dysthymia. It usually starts slowly, often beginning in childhood and teenage years, and can have a steady or fluctuating pattern of milder dysthymic features. Patients with dysthymia often have a family history filled with both depression and bipolar disorder. So there may be a link of uh, genetic loading in the patients of dysthymia. They have their relatives with depressive disorder and or bipolar disorders. The dysthymia diagnosed as not currently fulfilling the criteria for recurrent depressive disorder, mild or moderate severity in terms of either severity or duration of individual episodes. So basically in dysthymia, it even does not fulfill the criteria of mild depression. Sufferers usually have periods of days or weeks when they describe themselves as well, but most of the time they feel tired and depressed. Everything is an effort for them, and they express that nothing is enjoyed. They brood and complain, sleep is disturbed, and they feel inadequate, but are usually able to cope with the basic demands of everyday life. So there is no major impairment in their life, so they do not tend to seek the treatment, and they are also misdiagnosed. Dysthymia therefore has much in common with the concept of depressive neurosis and neurotic depression because of these features. In epidemiology, dysthymia is a common condition that affects about 5 to 6% of people. It is often found in general psychiatric clinics, impacting between one third and half of all the patients there. The rate of occurrence do not differ by gender, it is equally present in both the genders. However, it is more prevalent in women under 64 compared to men of any age. It is also more common among young people, those who are unmarried, and individuals with low income. Often occurs alongside other mental health issues, especially major depressive disorder, which makes it less likely for patient to fully recover between episodes. This means the major depressive episodes are there, like in recurrent depression, but the intervening period is not fully free of the symptoms. The dysthymic symptoms may be present uh, continuously in between the episode, and it is also called as double depression. So one dysthymic feature and the features of recurrent depression are present, or depressive episode is present, is called as double depression. Additionally, patients may experience anxiety disorders, substance abuse issues, and borderline personality disorders. The disorder is more frequent in people who have close family members with major depressive disorder like depressive episodes or recurrent depression. The diagnostic guidelines of dysthymia. The essential feature is a very long standing depression of mood which is never or only very rarely severe enough to fulfill the criteria of recurrent depressive disorder of mild or moderate severity. It usually begins early in adult life, lasts for at least several years, sometimes indefinitely. When the onset is later in life, the disorder is often the aftermath of discrete depressive episodes and associated with bereavement and other obvious stress of the later life. This includes depressive neurosis, depressive personality disorder, neurotic depression, persistent anxiety depression, which were previously classified or or known for the uh, dysthymia-like features in previous classifications. Is it excludes the diagnosis of dysthymia excludes anxiety depression, bereavement reaction uh, lasting less than 2 years, prolonged depressive reaction, and residual schizophrenia, in which the few symptoms of schizophrenia are remain there even after the best of the treatment. The differential diagnosis for dysthymia is obviously depressive disorder, recurrent brief depressive episodes or recurrent depression, and double depression as we have discussed earlier. Alcohol and substance abuse may the chronic substance abuse pattern may have features of dysthymia, maybe the differential diagnosis. Now, course and prognosis of the dysthymia. Approximately 50% of individuals diagnosed with dysthymia exhibit a gradual emergence of symptoms prior to reaching the age of 25. So 50% of patients may acquire the dysthymia before the age of 25. Despite the early manifestation, many patients endure these symptoms for up to 10 years before pursuing psychiatric intervention. Those who experience symptoms at an early age are at increased risks for developing either major depressive episode or bipolar 1 disorder over the course of their illness. Research involving patients diagnosed with dysthymia reveals that around 20% transition to major depressive disorder in future, 15% uh, diagnosed as bipolar 2 disorder had changed the diagnosis of dysthymia is changed to bipolar 2 disorder in case of 15%, and fewer than 5% to bipolar 1 disorder. So the person is having dysthymic features for the long time, and they may have episodes of mania or hypomania in the future, may be diagnosed as bipolar disorder. The outlook for individuals diagnosed with dysthymia is not uniform, can differ significantly among the patients. The administration of antidepressant medication along with certain forms of psychotherapy such as cognitive and behavioral therapy has been shown to yield beneficial outcomes in the management. Overall, the prognosis is good with the treatment. The treatment of dysthymia, the first line treatment should be psychotherapies like cognitive therapy, behavior therapy, insight oriented psychotherapy, interpersonal therapy, family and group therapies. If any kind of conflict in the family which acts as a perpetuating factor for the symptoms. Pharmacotherapy, the selective serotonin reuptake inhibitors SSRIs, specifically venlafaxine and bupropion, are effective therapeutic option. Venlafaxine and bupropion also have the low switch rate proportion and can be the first line treatment choice for dysthymia. Now coming to the cyclothymic disorder. Cyclothymic disorder can be understood as a less severe variant of bipolar 2 disorder marked by alternating period of hypomania and mild depressive episodes. A chronic fluctuating mood disturbance is characterized by multiple episodes of hypomania and depression. This condition is distinct from bipolar 2 disorder, which is defined by the occurrence of major depressive episode alongside hypomanic episode rather than minor ones. So what happens in cyclothymic disorder? The Episodes towards the depressive side uh, is somewhat matching with the features of dysthymia and not amounting to the uh, condition fulfilling with the criteria of moderate depression. On the high sides, hypomanic features may be present and not amounting to the episodes of mania. 3 to 5% of all psychiatric outpatient may be particularly characterized by substantial issues related to marital and interpersonal conflict. The patients, the patients usually present with the marital conflicts or interpersonal relationship issues, which may be secondary to the mood swings of the person and later to be diagnosed as cyclothymic disorder. The lifetime prevalence of the cyclothymia is about 1%. It frequently coexists with the borderline personality disorder. Male to female ratio is 3:2. 50 to 75% of individuals experiencing the onset of symptoms between the age of 15 and 25 years. In the etiology of cyclothymia, biological factors are there. Approximately 30% exhibit positive familial history of the bipolar 1 disorder, and the p degrees of families affected by bipolar 1 disorder frequently reveal multiple generation of individuals with bipolar 1 disorder linked by a generation with cyclothymic disorder. So in this flow chart, basically there is, you can consider the three boxes as a three generation. So if it has been seen that the first generation is having bipolar 1 disorder and the second is having cyclothymic features, and the further generation in the p degree may have bipolar 1 disorder, full-blown bipolar 1 disorder. So there is genetic linkage between bipolar disorder and cyclothymia is there. Around one third of the patients with cyclothymic disorder later develop major mood disorder. They demonstrate heightened sensitivity to hypomania induced by antidepressants. In these patients, antidepressants can induce hypomania or manic episode. Approximately 60% shows a positive response to the lithium treatment. Lithium is a mood stabilizer. Diagnosis and clinical features. The possibility of cyclothymic disorder is considered when a patient presents with the behaviors that may resemble sociopathy, and the patients present with marital history and relationship instability, promiscuity, and prolonged irritable mood, angerness in the personality. One can think of the cyclothymic disorder. Anecdotal evidence suggests that the hypomanic states can lead to heightened productivity and creativity, but most clinicians observe that the patient tend to become disorganized and less effective in their professional and academic pursuit during these phases. So, in the phase of high, one can be perceived as having heightened productivity and creativity. It's a myth, it's not true as per the larger observations. The instability usually develops early in adult life and pursues a chronic course, although at times the mood may be normal and stable for the months at a time. Short periods of normalcy may be found. The mood swings are usually perceived by the individuals as being unrelated to life events. So there is inappropriateness between the events and the mood. The diagnosis is difficult to establish without a prolonged period of observation or an usually good account of individual's past behavior. And a good informant must be there to reveal the mm, good psychiatric history of longer period of time. Because the mood swings are relatively mild and the periods of mood elevation may be enjoyable, cyclothymia frequently fails to come to medical attention. Mood changes, although present, is less prominent than cyclical changes in activity, self-confidence, sociability, and appetitive behavior. So mood is not a prominent feature. The things which will be revealed in the behavior is increased activity or the decreased activity in the phase of low. The self confidence of the person may be remain high for a longer period of time, then suddenly goes into the period of low self confidence. Sociability may be increased in the phases of high, and appetitive behavior may be seen in the phases of high, uh, and the reverse of these behavior is seen in the low phases. In the diagnostic guidelines, as per ICD-10, the essential feature is a persistent instability of mood involving numerous periods of mild depression and mild elation, none of which has been sufficiently severe or prolonged to fulfill the criteria of bipolar affective disorder, which is also called as bipolar 1 disorder, or recurrent depressive episodes. This implies that individual episodes of mood swings do not fulfill the criteria of any criteria described under the manic episode or depressive episode, even of the milder severity. The diagnosis includes the previously known as affective personality disorder, cycloid personality, cyclothymic personality. The differential diagnoses are: patient may have seizure disorder, may have substance abuse disorder, particularly the cocaine, amphetamine, and steroids. In the personality disorders, one can be one can the differential diagnosis can be borderline personality, antisocial, histrionic, and narcissistic personality. In the teenage group or earlier aged population, ADHD may be the differential diagnosis. The longer period of dysthymia should be discriminated from attention deficit and hyperactivity disorder. The course and prognosis: certain individuals diagnosed with cyclothymic disorder often exhibit traits of sensitivity, hyperactivity, moodiness during their childhood period. The clear manifestation of cyclothymic disorder symptoms typically begins during the adolescent period or early adulthood. The onset can significantly impede an individual's academic performance, that should be looked upon, and their capacity to form social connection with the peers. So poor social connections may be found in the history of present illness or the past illness. In the treatment, in the biological therapy, mood stabilizers and anti-manic medications are the primary treatment option for cyclothymic disorder. Carbamazepine and valproate are said to be effective. The doses and plasma levels of these medications should match those with the which we use with the bipolar 1 disorder. These patients are more likely to have hypomanic and manic episodes triggered by the antidepressant. So antidepressants should be used judiciously, or one should try to avoid the antidepressants in the case of cyclothymia, because around 40 to 50% of those with cyclothymic disorder who receives antidepressants may experience the hypomanic or manic episodes. In psychosocial therapy for the patients with cyclothymic disorder, psychopathy should be focus on helping them understand their condition and build skills to manage their mood changes. Therapists often assist patients in addressing any harm caused to their work, the family relationship during the hypomanic episodes. Since cyclothymic disorder is a long-term issue, patient typically needs ongoing treatment, long-term treatment. Family and group therapy can provide support, education, and healing for both patients and their loved ones. So, in the overview of mood disorders as a whole, disorders, often referred to as affective disorder, are a group of conditions characterized by disturbance in person's mood, leading to emotional instability or mood swings. The primary category of mood disorder include depressive disorders and bipolar disorders. In depressive disorders, one will find the depressive episode, recurrent depressive disorder, or persistent depressive disorder, which is dysthymia. In bipolar disorder, one can have bipolar 1 disorder, 2 disorder, and cyclothymic disorder. In etiology and risk factors, the genetic factors, biological factors, psychological factors, and environmentals all play a role into it. In the treatment, medication, psychotherapy are available, and lifestyle changes are also found beneficial in mood disorders, like regular exercise, healthy eating, adequate sleep, and stress management techniques. In conclusion, mood disorders are complex and multifaceted disorders requiring a combination of approaches for effective management. Early diagnosis and intervention are crucial for improving outcomes and enhancing the quality of life for individuals affected by these conditions. Thank you.